Good afternoon and morning for those of us who are still before noon, which is not me, but jealous to those of you who are. Welcome to day 2 of the virtual Hep B United TB Elimination Alliance mini summit. We hope that you were all able to join us yesterday for day 1, which was an exciting conversation about access to the people. Today, forward. If you haven't updated your Zoom, please be sure to do so. It makes it easier, especially later today for some breakouts. Additionally, though, welcome to day 2, which is reaching all populations. And today we're going to talk about, we're going to kick off with a workshop around some of the latest policy updates that would impact reaching our communities. And then we're going to move into a panel and breakout conversations around asking the tough questions, really looking at health equity and the social determinants of health as it relates to our work within hepatitis B and TB. And I am just so excited for the folks that we have on this panel and our audience's ability to engage with them moving forward. Sorry, give me 1 second to pull up my next set of notes. Wanted to, so yes, thank you all for attending. If you were here yesterday, some of what I'm about to say is going to be a repeat, but for all the rest of you, this might be new. So we are hosting this year's mini summit virtually through Zoom meetings. This year is our 10th summit for Hep B United. It is our 3rd one virtually, and it is our 2nd one in coordination with the TB Elimination Alliance. Since this is virtual, we'll be using Zoom meetings as a way to try to have as much interaction as possible for folks. But with that, we ask that everyone put your name for your video box so we know who you are. Throw in your preferred pronouns and an organization as well, if you'd like. It'd be helpful for just all of us to know who it is that we're spending shared time with. We really hope to make use of the chat boxes during Q&A. And yesterday there was quite a bit of information being passed around, whether it was questions or just different panelists and moderators giving resources for folks to be able to use. Many of the presentations throughout this week are pre-recorded, but in almost all instances, we plan to have that presenter back for live Q&A. And that's just helped to help cut down on potential technology issues. But as such, we may have to take a minute or two here or there to fix a slide, get something going. So we just ask that you bear with us and give us some patience and grace in this virtual space. We ask that you please keep yourself muted, as I'm sure you've had presentations to have folks pop in with barking dogs and Starbucks orders and whatnot. Just keep yourself muted if possible, and if you accidentally come off mute, don't feel any sort of way if one of us remute you. We still love you, no worries. Additionally, we want to say that in order to keep this summit as beneficial as possible to the community, we ask that you please fill out the evaluation form. Your answers can be submitted anonymously. It doesn't matter if you attend one session or all 9. We would love to hear your input on what worked and didn't, what you might like to see next year for our in-person summit, knock on wood, and everything else that we might be doing for future summits. Again, I would be remiss if I did not thank our amazing steering committee from the Association of Asia Pacific Community Health Organizations, or APCHO, from the Hepatitis B Foundation, from the Stop TB Now, as well as the Asian Pacific Islander American Health Forum. These 4 organizations help convene Hep B United, as well as the TB Elimination Alliance. And these individuals here really came together to put the agenda together, to reach out to speakers, to ensure that audience participation was doable, so on and so forth. So just a big thank you to everyone who has helped with that. Additionally, over the last week, we've asked attendees to send us songs they felt matched one of the day's themes. We introduced those themes yesterday. You heard Rise Up by Andra Day coming in today, and we have some other great choices coming on later. But there's still time to get some suggestions in for actually for some breaks later today. I could use a couple more songs, as well as there's some time for tomorrow. So please, there'll be a link probably dropped in the chat. You might have seen it also on the email from before the summit today about an opportunity to submit some songs. So with that, I am going to stop sharing my screen and turn it over to have Dr. Philip LoBue, who is the director of the Division of Tuberculosis Elimination in the CDC's National Center for HIV, Viral Hepatitis, STD, and TB Prevention. We are thrilled to have a welcome video from him, and want to say that Dr. LoBue has been received their undergrad and medical degrees from the University of Pennsylvania, received his postgraduate training in internal medicine and pulmonary and critical care at the University of California, San Diego, where he was subsequently a clinical professor in the late 90s. Then moved into becoming a medical epidemiologist in San Diego County. And then in 2004, we were lucky enough to have Dr. LoBue move to the CDC headquarters. He's involved in all of the different boards and colleges of physicians that one might be when handling TB prevention, but also wanted to flag that he's authored or co-authored more than 80 publications, including journal articles and morbidity and mortality weekly reports, and has served or chaired on more than 10 guidelines and recommendation committees and panels for organizations like the CDC, and the World Health Organization. So really just understands the intersection of healthcare and where this policy can be changed. So with that, I'm going to turn it over to Dr. LoBue. Oh, give me 1 second. See, these are those tech issues.
I know she keeps saying that she's busy running one errand and other. Without very listening.
Just one moment. It's coming. All right. Well, that was fun. We will make sure to get Dr. LoBue's video played today. For some reason, the audio is no longer coming through. It's come through for all of the other test runs, but not for this one. So with that, we're actually just going to continue right along. And we will make sure that this welcome gets played before we close out today.
Frank, do you want me to play it?
Do you have it with you?
I do have it. Yeah.
Oh, let's do it. Thank you, Adam, for the win. Here we go.
Hold on. Okay, let me just make sure I have
Make
this.
you a co-host.
Cool, thanks. Share screen. Can everyone see that?
Yeah.
I'd like to thank Hep B United and the TB Elimination Alliance for their innovative partnership to reach Asian American, Native Hawaiian, and Pacific Islander communities, as well as T's expanded efforts to reach organizations and agencies working with Hispanic and Latino and African American communities through education and awareness on hepatitis B and TB. Today, I'll briefly cover current TB trends and what DTBE is doing to address health equity and our division's current and future priorities. Although the United States reported a record low number of cases, too many people still suffer from TB disease in this country. In 2021, reported incidence in the US increased 9.4% from a historic low in 2020, but remained 12.6% lower than in the 2019 rate. The COVID-19 pandemic has had substantial effects on US TB disease trends. Factors contributing to changes in reported TB during 2020 to 2021 likely include an actual reduction in TB incidence, as well as delayed or missed TB diagnoses. Timely evaluation and treatment of TB disease and latent tuberculosis infection remain critical to achieving US TB elimination, especially for our prioritized populations most at risk for TB. In the United States, most TB cases occur among racial and ethnic minority groups. Asian persons represented the largest proportion of persons with TB at about 36%, followed by Hispanic and Latinos at about 30%, and Black and African American persons at 18%. A disproportionate number, 71% of US TB cases occur among persons born outside of the US, largely because of progression of long-standing latent TB infection likely acquired before arriving in the United States. To reduce disparities among populations most affected by TB, DTBE is committed to promoting and advancing health equity in both organizational and program level TB control and prevention efforts. Last year, CDC launched an agency-wide strategy to integrate health equity into all agency public health work with the goal of reducing health disparities. To incorporate this strategy, DTBE developed 3 goals that focus on populations who experience health disparities related to TB disease. The overall goal is to reduce TB incidence in these populations by about 20% between 2019 and 2025. Most TB cases among non-US born persons occur among those who have lived in the United States for many years and are likely the result of reactivation of latent TB infection. Reducing TB incidence in these populations and reaching the goal of TB elimination in the United States requires a dual approach of maintaining and strengthening current TB control priorities while also increasing efforts to test and treat latent TB infection among populations most at risk for developing TB. With that approach in mind, the division has undertaken several activities focused on latent TB infection testing and treatment in non-US born persons. In March, we rolled out the first national multilingual communications campaign, Think, Test, Treat TB, to increase testing for latent TB infection among Asian Americans. In addition to working with traditional TB partners such as state and local health departments, the National TB Controllers Association, Stop TB USA, and the TB Centers for Excellence on this campaign, we also engaged organizations and agencies serving Asian American communities, including our colleagues at the TB Elimination Alliance, the Filipino Community of Seattle, the Philippine Nurses Association, International Community Health Services Clinics, and others. Since the launch, we've had over 55,000 visits to the Think, Test, Treat TB website and shipped over 35,000 educational materials to 44 states, the District of Columbia, and 4 territories, and also US affiliated Pacific Islands. Early indications from the campaign evaluation data showed that the campaign was successful in raising awareness of latent TB infection among priority audiences, including people born in the Philippines and Vietnam, as well as their healthcare providers. We are now in the 3rd funding cycle for the Tuberculosis Epidemiologic Studies Consortium. The objective of TBES3, as it's called, is to better understand which interventions related to latent TB infection, targeted testing and treatment are most effective and efficient in primary care settings. Healthcare providers are crucial to the successful expansion of testing and treatment initiatives for people with latent TB infection. The 4 TBESC3 study sites will collect retrospective and prospective electronic medical record data, design and implement clinical care-based interventions to improve performance measures from the initial tuberculosis screening through treatment for latent tuberculosis infection and monitor and evaluate intervention performance over time to identify efficient and effective strategies. Additionally, we recently awarded 4 recipients with 2-year cooperative agreements to develop pilot projects to establish surveillance and improve linkage to care and treatment of latent TB infection among non-US born persons living in the United States on temporary visas who apply for permanent residency and are examined by civil surgeons as part of the application process. Engaging with communities disproportionately affected by TB through capacity building efforts like the TB Elimination Alliance and the Think, Test, Treat TB campaign can help raise awareness of TB prevention and promote testing for and treatment of latent TB infection. We must continue to ensure correct and timely diagnoses, focus on essential TB prevention and control activities, and expand services equitably and address persistent disparities in TB. I would like to conclude by acknowledging the TB Elimination Alliance and Hep B United for their collaboration and work to bring together community organizations, healthcare professionals, public health, and others who work to address these important issues surrounding hepatitis B and TB. We look forward to the opportunities to continue and broaden our partnerships in the upcoming years to develop and implement approaches which address all healthcare needs for the individual and to facilitate optimal health outcomes. Thank you.
Thank you, Dr. LoBue, for that lovely introduction, and thank you, Adam, for that tech assist. With that, we're actually going to move into our first session. Let me share the screen real quick so you all can see what it is. We're going to move into our first session, which is about the latest policy updates around hepatitis and tuberculosis. And so for this, I'm actually going to turn it over to Daniel Raymond from the National Viral Hepatitis Roundtable to lead our discussion.
Thanks, Frank. And hi, everyone. Happy to be here with all of you today. Frank, can you hear me all right? Okay. If my voice sounds a little raspy, I thought that I would get into the spirit and develop a respiratory infection. So apologies for that, but I'm really excited to support this panel. To those of you who think that policy is boring or ugly or don't want to hear anything about the elections happening in the United States next month, these 3 speakers are going to change your minds. I'm really happy to be here with Frank, with Adam Carrillo from APSHO, and filling in for Cecily Campbell will be another colleague from CDC, Nora Spencer-Lovell, Senior Advisor for the Office of Policy Planning and Partnerships, National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. So we'll start off covering the latest policy updates, advocacy, and legislation in the hepatitis B and TB space. Each of the presentations is going to be about 10 to 12 minutes, and we'll do them back to back. But I will facilitate a Q&A afterwards, so save up your questions and feel free to use the chat to react, to tell us what's on your mind, to flag any things that you'd like to make sure that I bring up in the Q&A section, and we'll do our best to field them. So with that, I'm going to start with Nora and our presentation from CDC.
Thank you so much, Daniel, and it's such a pleasure to be here. I am Nora Spencer-Lovell, not Cecily Campbell, who is my much smarter boss, but I'm going to do my best to share some information with you and give you a little glimpse about what CDC is doing in the federal space. First, I'd like to thank not only my esteemed co-panelist and moderator, but also you for joining today and inviting us to speak. I took a quick glance at the participants and I'm a little starstruck because I know many of you by name, and that's due to the amazing and very important work that you're doing. So thank you so much for that and for allowing us to be your partner in that work. In NCHH STP, that's our nickname for our center, as Daniel described, the National Center for HIV, Viral Hepatitis, STD, and TB Prevention at the CDC. We envision a future free of HIV, viral hepatitis, STIs, and tuberculosis. And to achieve this, we work every day to prevent infections, morbidity, mortality, health inequities, and stigma attached to our conditions. And we embody the values such as excellence, equity, diversity, inclusion, accessibility, and belonging, integrity, and transparency. These aren't just buzzwords for us. We really focus our work on 3 guiding principles: high impact prevention, cross-sector collaboration, and embedding equity principles in all aspects. And as I said, our goal is to reduce incidence, morbidity, mortality of HIV, viral hepatitis, STIs, and TB, but also core to our work is to reduce those disparities and promote health equity and to be an excellent organization. So it's no surprise many of you are familiar with our work and really integral to it, but we do kind of 6 buckets of work that include the use of strategy, surveillance to maximize its use and pair that with other data to really drive program improvement. We, of course, support scientific discovery as well as implementation research and evaluation of those interventions. And we really want to collaborate and integrate services where we can to really serve people and improve health across the nation. We promote prevention, detection, and treatment through healthcare delivery systems. We promote protective systems and policies and increase knowledge and adoption of healthy behaviors. So you'll see that a lot in our school health work, which is not reflected in our name, but certainly core to our activities. And of course, we use guidelines and policy to improve public health. Our center at CDC has long invested in programs and research that save lives and money. For example, we did some research that showed over a 10-year period, the US TB control efforts have prevented 319,000 TB cases and averted up to $14.5 billion in cost to society. That's one area where we work is to show a return on investment in these very important programs. And we've worked for decades to reduce infectious diseases and health disparities throughout the United States. Our research and programs are working to confront disparities related to race, ethnicity, and geography that have contributed to prevention gaps for far too long. And I'm sure I don't have to tell many, if not all of you on the call, that it's true that some groups of people in the US experience a greater health burden of viral hepatitis and tuberculosis, as well as STDs, HIV, and youth risk behaviors, with more illness and death overall than other groups. You may know that TB case rates are 33 times higher among Asian persons than white persons, and deaths are substantially higher among Asian persons with hepatitis B virus than for persons of all other races and ethnicities. This is not okay. And CHHSTP has supported the planning, implementation, and evaluation of innovative and interdisciplinary interventions that address social determinants of health, including racism and other forms of social discrimination, which contributes to STD and HIV and viral hepatitis and TB disparities. We also know that social factors such as poverty, unstable housing, lack of access to transportation, and identity status negatively affect retention and care. And so we're funding programs and building partnerships across federal agencies, so we're not working so siloed, to increase those linkages to the social support services people need to avoid infection and remain in proper care, as well as just be okay as humans. We are looking for ways that we can do better, both externally, but also internally around equity. So one project I want to talk to you about is called the HHSTP Equity Initiative. And it's breaking new ground by intentionally and systemically looking to integrate equity into everything we do. It's a transformational long-term strategy to help us achieve equity within our workplace and eliminate health disparities by addressing the racism and other systems of oppression that hinder our center's mission. So today, we have done an analysis of our workforce to identify representation gaps, workplace culture trainings for staff, and OD and division specific equity plans. But future activities for 2022 include a final monitoring and evaluation plan so we can have accountability for our goals, and guidance on evidence-based interventions, policies, and best practices to reduce these disparities. So we think we have to work internally in order to do great work externally as well. Now, our center also prioritizes strategies that reduce infectious diseases among people, associated with drug use, and to help people who use drugs improve their health and prevent infections, and truthfully, as a nation, better prepare us for emerging public health threats like we've experienced with COVID-19 and monkeypox. Strengthening syringe services programs in the infrastructure nationwide and further integrating SSPs into the US public health system is a center priority. And as we look to the future, our center is embracing a syndemic approach to our diseases. So looking at ways to incorporate multi-disease interventions where that affect a specific population or in a specific place or aided by a specific strategy. Syndemic strategies really create an opportunity for whole person service delivery with focus on populations overrepresented in the viral hepatitis, TB, STI, and HIV space. And our harm reduction work is a prime example of this. A syndemic approach allows us to support holistic service delivery and increases efficiency and cost effectiveness by addressing multiple outcomes at the same time, and really aims to affirm the natural relationship developed by harm reductionists and the communities they serve while reducing stigma and advancing any positive change as a good step. We really want to get out of the way. Our syndemic approach is rooted in partnerships, policy, and social determinants of health drivers. Increase flexibility by enabling partners to adapt and implement and even modify integrated services to increase responsiveness to evolving epidemics or changing contexts, and providing implementing partners with increased control and ability to provide these comprehensive services. So as I said, a syndemic approach really allows us to support holistic service delivery. But this makes service delivery efficient and cost effective by addressing multiple outcomes at the same time. And I said before, it really affirms the natural relationship and that trust developed by practitioners and the communities they serve. So one of the things we're really focused on addressing now, as we're in the process of assessing how administrative, financial, and managerial barriers and processes could be changed to address or could be implemented to allow for a syndemic approach to address multiple diseases at once. So for example, you might recall the Hep A outbreaks that happened over the course of the several years ago. It was kind of one of our largest priorities before COVID hit. We look for ways to make more accessible vaccinations for hepatitis B as well, when we were able to provide vaccinations for hepatitis A for people experiencing homelessness and people who use drugs. And similarly, our viral hepatitis program right now has a project in Alaska helping hard to reach populations, many times simply because of geography, get multiple vaccinations like COVID and hepatitis A and B at the same time. Another example, though, of our syndemic approach is policy change. So we look for ways in which we can leverage policy change to serve the populations that we serve across multiple disease areas. So there's one project I want to be sure to tell you about before I close, and that is our Policy as a Public Health Intervention project. It's core to our work, and this program establishes the enabling environments that embrace evidence-based policy strategies to achieve our goals of a future free of HIV and TB, hepatitis, and STDs. So this is done by funding nationally recognized NGOs who share similar goals in state policy, establishing non-funded partnerships that inform and amplify and then disseminate our state policy initiative strategies, monitoring and evaluating available data, so that might be health, law, or policy data, to keep informed of emerging state policy issues affecting health, developing metrics to inform a dashboard to monitor progress in advancing certain policies, and conducting policy and legal surveillance to inform potential legal research activities to produce evidence that further amplifies our work. So stay tuned for more information about this very important project. You'll hear a lot about it in the coming months. I'll close today. I gave you a lot of information. It's meant to be a very big picture overview, but I welcome further conversation both today and in the future. And I'm so grateful for the opportunity to share more about our work. Thanks.
Thank you so much, Nora. Now I'm going to turn it over to Adam Carballo, the Director of Policy and Advocacy for APCHO, the Association of Asian Pacific Community Health Organizations.
Thanks, Daniel. And thanks, Nora, for that incredible presentation and just learning and hearing of all the incredible things that are being done at the CDC. As Daniel mentioned, I'm Adam Carballo. I'm the Director of Policy and Advocacy with the Association of Asian Pacific Community Health Organizations, or APCHO. And I'm going to apologize at the top of this because, we heard a lot of the things that are being done within the administration and over at the CDC. I'm going to apologize because I'm going to talk about some of the things going on in Congress. So forgive me if this is a little bit of a downer presentation part, but I promise Frank will get to a happier aspect of some of the advocacy that we're working on. I think many of you know who APCHO is, so I won't have to go through these. But I did want to give a kind of a 50,000-foot view of the political landscape that we find ourselves in right now, because this summit is happening at kind of an odd period of time. We're about 13 days from the midterm elections. Congress is not in session right now, and there's going to be a flurry of activities in the lame duck once the midterms are concluded and the election outcomes is decided. And I think some of the end of year legislation is going to be largely influenced by how the election results turn out. As while the current Congress will continue to be in office for about 2 months, a lot of what the priorities for both the Republicans and the Democrats have in the lame duck session is going to be influenced by the outcome of the midterm elections. And just so that everybody, we can level set with everyone, I'm sure you all are aware of the elections that are coming up in just 13 days. If you haven't already voted early, I hope you all have a plan to get out and vote and make your voice heard in choosing your representatives and your elected officials. But there are 35 senators who are up for re-election. 14 of them are Democrats, 21 of them are Republicans, and really any change in a seat in the Senate can change the party that's in power in the Senate and influence how the Senate is going to be acting in the 118th Congress. All 435 voting members of Congress are up. There's an incredibly slim Democratic majority in the House of Representatives as well. Republicans only need 5 seats in order to take the majority, and there's already been some indications of what the priorities are going to be if there's a change in leadership in the House of Representatives. I'm not going to get too much into the political aspects of these races, but I did want to just lay out here what the current polling is showing on what are the toss-up races and the most competitive races in the House of Representatives. If you see your member of Congress or your district on these, just pay attention to it. And again, I hope you have a plan to get out and vote in November. Similarly, in the Senate, it's an incredibly tight midterm election, and a change in any one of these seats could change the balance of power in the Senate. So I just wanted to provide kind of that context of what we're looking at as we enter the lame duck and going into the 118th Congress. Going into the lame duck session, there is a huge amount of work that Congress still has to get done before the end of the year with government funding, with reauthorizing the Defense Department, as well as ensuring that other priorities and policies that need to get done before the end of the year are actually enacted into law. Shortly before Congress went into recess at the end of September, they did pass a continuing resolution that extended government funding at the FY22 levels until December 16. So they will have until December 16 to either pass another continuing resolution or pass an omnibus bill to maintain government funding for the remainder of the fiscal year, or for however long another continuing resolution will be. We are starting to hear rumors right now that Congress may need an additional week in order to get its work done, unfortunately. So there might be a very short 1-week extension to this December 16 deadline. If anybody at the summit does work at the national advocacy space, don't plan your Christmas holiday until we know the outcome of the elections, because we could be in for another week. As I mentioned, the House and Senate have to deal with appropriations. House and Senate leaders have not yet agreed to top-line numbers for spending levels for fiscal year 2023, while the House Appropriations Committee did pass out all 12 of its appropriation bills for FY 2023 and did pass half of them. 6 of the bills did pass the full House of Representatives. There hasn't been complete agreement between the two chambers or between the two sides. Of note for the programs that we are all interested on this call, the full House has not yet passed the Labor, Health and Human Services bill or the State and Foreign Ops bill. Both of those deal with programs both at the domestic as well as the international aid for hepatitis B as well as for tuberculosis. Senate Democrats did release the text of their appropriations bills in late July, but there have not been any hearings or any movement on the Senate appropriations side. There's likely to be no hearings on Senate appropriations between now and the end of the fiscal year, or between now and any period of time when they have to pass appropriations. So we're likely going to go into either an omnibus or, like I said, another continuing resolutions. And appropriators are likely not going to start negotiations on those bills, at least the big picture, the big ticket items on those bills, until after the midterm elections. Like I said, they want to see the outcome of which party is likely to be in power in the 118th Congress in order to decide what programs are going to go into the omnibus bill at the end of the year. In addition to appropriations, there's a growing desire and a growing sense of a priority in order to address the debt limit that will have an expiration date in towards the end of next year. But Senate Democrats or congressional Democrats right now are looking to address the debt limit in order to take the negotiations off the table for next year. There is concern that it could be used as a political tool, kind of what happened in 2012 for those of you who were in advocacy back then, as well as in 2017 when we went through the debt limit negotiations again. It could be used as a bargaining chip in order to make reforms to certain entitlement programs. I know that there are thoughts about tinkering with either Social Security or Medicaid, and Democrats really don't want to have to do that and are trying to take it off the table for the 118th Congress. In addition to appropriations, there's a whole flurry of other legislative priorities that Congress is looking to get done before the end of the year. They have to address some of the hurricane or disaster relief and replenishing the disaster relief funds, particularly after the hurricanes in Florida and in Puerto Rico. There is a fiscal cliff for the territory's Medicaid program that expires on December 16 with the expiration of the continuing resolution. Without congressional action, the Medicaid program in the U.S. territories will no longer have the additional FMAP, the additional matching funds that the government provides to support their Medicaid programs, as well as an expiration of additional funding for that is utilized for Medicaid programs. There's a strong desire to address the mental health challenges that are affecting the nation, particularly as we're coming out of the COVID-19 era. Telehealth extensions need to be addressed, especially as we're looking towards the end of the public health emergency and the temporary flexibilities that were granted with the public health emergency, as well as several other legislative priorities that Congress is going to try and loop into this omnibus appropriations bill. As we're looking towards appropriations, just to give a flavor of what was included in the House bill, the House bills, as well as the Senate Democrats provisions, there were slight increases to TB funding that House appropriators are proposing. There's a $5 million increase in the domestic tuberculosis program within within CDC, as well as another $5 million increase that's being proposed for fiscal year 2023 for the global TB health program, also administered by CDC. And on the state and foreign ops side, administered by USAID, there's also an increase that we're looking for global funding for TB programs that House appropriators are proposing. On the Senate side, as I mentioned, there's been less action that has happened on the Senate side. There's actually not a lot of detail to what goes into the top line numbers for the programs, but I did include that that Senate appropriators are also looking for some increases in the big umbrella buckets where TB and hepatitis B programs live. Also, like I said, we're in a kind of strange period of time right now where the current Congress is winding down. But in this Congress, we did see some advancement of TB legislation. There have been 2 bills that have been introduced and both have bipartisan support in addressing some of the TB challenges. The Anti-Tuberculosis Act now has been introduced in both the House and the Senate, and it does have bipartisan support, at least in the House of Representatives. The Comprehensive TB Elimination Act, also introduced in both chambers, also has bipartisan support for these. I think as we're looking towards the 118th Congress, it'll be an opportunity for additional advocacy about moving these bills and seeing if we can get some either momentum building or enactment in the 118th Congress. I don't really think that there's an opportunity for advancement in this Congress, unfortunately, since we are winding down at this time. Like I said, a lot of the challenges that we've seen over the last several years in addressing both TB and hepatitis B has been heavily impacted by COVID-19. But as we're looking towards the next several months, there is an indication that we are likely to be moving out of the COVID-19 era, at least in terms of the public health emergency and the administration's efforts to start to unwind the public health emergency, just so that we can level set on what this actually means and why it's important for TB and hepatitis B programs. Since 2020, Congress has required that states continue to maintain enrollment for most individuals who are enrolled in Medicaid and CHIP until the end of the month that the public health emergency ends. So what that means is that states couldn't generally disenroll individuals who enroll low-income individuals who were enrolled in Medicaid or CHIP until the during the public health emergency. And since 2020, or as of July of this year, more than 89 million individuals in the US are currently enrolled in healthcare coverage through Medicaid or CHIP. As part of the redetermination process, HHS has estimated that approximately 15 million individuals will lose coverage during the unwinding period. And this is significant because it represents about 17% of all Medicaid and CHIP enrollees today. And predominantly, it could have a disproportionate impact on children and communities of color. What CMS has provided guidance to the states is that when they do start their eligibility redetermination process, they will have 12 months from when the PHE ends to initiate Medicaid redeterminations, with an additional 2 months to complete that process. So while it is 14 months in total, that is going to go, we know that's going to go by very quickly, and it has the potential to significantly impact communities and individuals who are most at need of healthcare coverage. Where are we today? About 2 weeks ago, Secretary Becerra did announce that the public health emergency would be renewed for another 90 days. So the PHE is currently slated to be in effect at least until mid-January of 2023. The Biden administration has committed that it'll provide a 60-day notice before it will end the public health emergency. So we'll excuse me, we'll get a sense of whether what the administration's plans are with the PHE around the middle of November. So about November 15, if we hear that the administration is going to be ending the PHE in January, we'll get a notice from HHS at that time. If we don't hear anything from the administration, it's likely a signal that the PHE will be extended at least one more time for another 90 days. Where are we on the time? This is just a visual on the timeline that we're at now. Again, the current status, PHE was extended back in October 14, for another 90 days until the middle of January. So January 15, we should get a 60-day advance notice if they are going to end the PHE in January. So we'll know around November 15 if the PHE is going to be ending. As I mentioned a little bit earlier, the continuous coverage protections for individuals to be in where states couldn't disenroll individuals from Medicaid or CHIP will be lifted at the end of January if it does end in on January 15. The additional money that was tied that was given to states in order to continue to cover the Medicaid beneficiaries will expire at the end of March. And some of the telehealth flexibilities that we have would expire in the middle of June. It's there's some quirky, Congress provided 151 days after the end of the PHE for some of the Medicaid telehealth flexibilities to expire if they don't act otherwise. If we do hear that they are going to extend it for another 90 days, this second row would just move out that timeline by another 3 months or so. And why is this important? Who does this impact? So ASPE did issue a report back in August on the implications of the PHE unwinding. Like I said previously, approximately 15 million individuals, or about 17.4% of the current Medicaid enrollees would lose coverage. And it would have significant implications for racial and ethnic populations and children. And there are two buckets of where we see this, where we see the implications being. First is that about 8.2 million of the individuals who would lose coverage because they are no longer eligible to be enrolled in Medicaid. So they should be transitioned into another health coverage plan. And about 2.7 million of these individuals are likely or are estimated to qualify for marketplace premium tax credits, so they'll continue to get government assistance. I think where we are most concerned on eligibility and enrollment in Medicaid is for about 6.8 million people. They'll lose coverage despite still being eligible for Medicaid enrollment, but they'll lose it for what's known as administrative churning. It's administrative requirements in order to verify their eligibility. It's that the Medicaid offices cannot, have not been able to verify that they continue to be eligible, either because they can't get in contact with these individuals. They need these individuals need to update their information with the Medicaid offices. But it is something that is preventable. They should continue to be enrolled in Medicaid, but the states have not been able to verify it, so they would have to be removed from the program if they don't update their information. For populations that APTO serves, and I'm sure that many of you and your organizations also serve, this could have significant implications for communities of color. As you see in the graph on the right, about half of the expected number of Asian Americans, Native Hawaiians, and Pacific Islanders who would be disenrolled during the redetermination process would be disenrolled, even though they would continue to be eligible for the program, but they wouldn't have been contacted to update their information and verify their eligibility. So, what is the reason why I'm bringing this up with this audience and with all of you is because, I hope everyone will be paying attention to the PHE unwinding when those determinations are made, and talk to your patients, talk to the individuals who you're serving, ensure that if they are on Medicaid or if they are on CHIP, that they do that they are in contact with the Medicaid offices, that they update the information with Medicaid to ensure that they don't lose coverage. I think it's absolutely critical that we try to keep as many people enrolled in this coverage, especially if they continue to be eligible for it. And it can have implications to the ability to get treatment or to get vaccinated for hepatitis B, for tuberculosis, for a whole other host of health issues. So just want to ensure that we're all aware of what's coming in the next several months and minimizing the impacts that they'll have on the communities and the individuals that we're serving. So with that, again, sorry if it was a little bit of a downer, but Frank, I'm going to hand it off to you. Hopefully you can turn it around and bring some happy news to the group.
Thanks, Adam. And I just wanted to say, on behalf of MHR, I've always been grateful for ABSHA's strong voice and effective advocacy. And I'm going to turn it over to another strong voice and effective advocate, Frank Hood, Director of Hep B United and Associate Director of Policy and Partnerships for Hepatitis B Foundation. Frank, bring us home.
Thanks, Daniel. And Adam, I'm not sure why you think I'm going to be like puppies and sunshines here, because I think I'm going to give us something to do about what you said. So hopefully that will be the positive I give. I'm going to make this quick so we have some time for some questions. Current state of policy as it relates to hepatitis B. Currently, there are almost 2.5 million Americans living with chronic hepatitis B, 300 million globally. Well, I'm rocking the shirt today. But really, we need to look at what's happening around the recent trends. So pre-COVID, if you look at the surveillance data from 2010 to 2019 put out by Nora's office and the Division of Viral Hepatitis, as well as the Division of Viral Hepatitis, you'll see that cases remained relatively flat. There were approximately 20 to 22,000 new acute cases each year. And that was what was recorded and estimated based off of modeling. We have belief that there are hidden cases in there not being captured, but in general, it showed a pretty flat curve. But what was shifting over some of those years is really where the cases were coming from. It is still very much a heavy burden within the Asian Pacific Islander community, the Native Hawaiian community, the African immigrant community. But we also started seeing more cases come up as a result of drug use as a potential risk factor. And so just, while the cases the number of cases may not have been changing, kind of where they were coming from started to. And then in 2020, the surveillance data for 2020 was just released in the last month or so, showed a really significant data gap as a result of all the impacts from 2020. And I actually think that data gap may exist beyond, and that's part of what I want to make sure to flag today. Because the 2020 surveillance data, based on what was given to the CDC, showed a 32% reduction in acute hepatitis B cases. But I think for most of you on this call who do testing, and then submit their tests to the local health departments or to the state health departments and understand how, kind of epidemiology and surveillance reporting works, I think many of you recognize that, this wasn't necessarily an actual reduction in cases, but an inability to, do the screening events that we were able to do, in 2020 and prior, as well as, have the people actually focused on hepatitis instead of being deployed into COVID response. And I flag this because these are still concerns and are about to be compounding concerns. We also need to look at, I mentioned some of the disparities that we're seeing within hepatitis B, but I wanted to flag this slide is to say there are some extreme disparities when we look at Asian Americans and Pacific Islanders, in the sense that it's they're less than 6% of the population, but account for more than 60% of all the chronic Hep B cases in the country. And in this most recent surveillance report, and props to CDC for flagging it, these were the top 2 points under their health equity pullout from the 2020 report. Rates of chronic Hep B among API persons were almost 12 times that than among non-Hispanic whites. And the death rate among APIs with hepatitis B were nearly 9 times that among non-Hispanic whites. And so there really is a disparity when it comes to hepatitis B. And then seeing that there is high infection rates within African immigrants. And again, as I've mentioned, there's been a continued shift towards people who inject drugs, and that risk factor remains high. In 2020, in the midst of COVID, from June to September, the Hep B Foundation, Hep B United, NVHR, NASDAD, HepBue, all the Heps, put out a survey into providers, whether it's clinical, community-based organizations, or health departments, to basically ask, like, hey, how's COVID treating you? And as you can imagine, the response back was not great. It was, hey, we're having really serious challenges. And what I wanted to flag on this piece is that under CBOs, the Hep B and C testing decreased significantly, vaccination decreased significantly, and community outreach decreased significantly. And for some of these populations, their touch point into getting to a clinical provider or a health department is through a CBO. It is a CBO on the ground in a location who is having the conversation, who has been like, hey, you know what? Let's connect you to this person over here, and to actually get them linked to vaccination or care. And when we lose that touch point on the ground, we lose everything else that comes behind it. So when we get a report that then says, hey, there's been a lot fewer cases, what we're seeing is like oh no, that means that there are missed cases out there that we really just need to catch up and find. And interestingly enough, HepBue just yesterday publicly released a new surveillance report that it's a survey of surveillance capacity within the country. And I wanted to pull out two pieces. This was the percentage of jurisdictions who were able to conduct investigations into suspected Hep B cases. And only 30% were able to go and review and contact people who may have been exposed, versus 80% being able to review. So there is clearly a staffing gap between when a case comes in for a jurisdiction and then what a jurisdiction is able to do after that. Additionally, and this shows both B and C, that gap becomes even more stark when you break it down between which jurisdictions have at least one full-time employee working on these sort of hepatitis surveillance labs, so like lab results, and getting them implemented, versus the jurisdictions without. And you can see that there is a significant decrease from about, for the jurisdictions without a full-time employee, they're only about 45% of them are even getting the negative lab results. But in order to then like use them for something, you see that big drop down, versus over here where you have at least one full-time employee, they're able to actually do their public health surveillance prevention work. So this is why I was like, Adam, I don't know why you think I'm going to come in with the sunshines and roses, because really I was coming in just to say is like, things are bad-ish. I mean, things are bad. Things could certainly be better. And I think, I think most folks right now would say like, hey, we still have to do COVID stuff. We still have to protect our people. We still have to provide education. We're still doing testing. We still want to get folks linked to COVID and bivalent boosters. Maybe these same folks are doing monkeypox. And so then to hear from Adam that like, hey, guess what? I know the federal government and your state governments through Medicaid and whatever else has been able to like give you some money to help do that. If that's about to dry up, how are we and how are you, all of you who do this work on the ground, going to be able to balance the normal work you're already doing, the increased work you have to do with COVID, and then the kind of digging out of the hole that we find ourselves in terms of lacking of tests and things like that. So real fast, what do we do? What do we need? Actually, don't go first. More resources. I mean, I'm just going to point to Adam's slide earlier because he actually that was the best slide for it. We have requests in as an advocacy community into Congress around funding for different places within the federal government that can provide the resources to folks on the ground in a variety of ways. And I'm going to actually dive into a couple of them right now. Additionally, so one of the ways we need to catch up on our tests, whether they're positive or negative, is with screening. And luckily, there has been an adjustment for screening, one-time Hep B universal screening for all adults 18 and older. And we're hoping that this will result in more insurances being able to cover a hepatitis B test. But we're really hoping that this results in more individuals going and more providers going and offering the screening, and then submitting that result to their providers or to their EPIs, their epidemiologists and surveillance folks. We also have a new, almost mostly universal hepatitis B vaccination. So it's universal for 19 to 59. And then for those who are 60 and older, it is recommended for those with risk factors. The risk factors are pretty long. Again, in the sense where standard treatment is you should go and screen someone before giving them the hepatitis B vaccine. Really implementing these new guidelines through ACIP is an opportunity for providers to have conversations around hepatitis B, to do hepatitis B screening, to use that screening result and you know, do that screen and give your first dose as what's been happening. And then when you're following up to that second dose, you know, have a conversation about what the test results were and potentially shift from that second dose into instead some sort of linkage to care. And this is especially important when we think about the fact that screening isn't just for the individual, it's for the people around them as well. And so when you screen an individual and are able to go back to them and let them know, no, you don't have Hep B, or yes, you have an active infection, it's also letting them know what they need to do or don't need to do to keep their family safe, their kids safe, their you know, maybe their parents safe. And then, so both with vaccine and screening, we need to do provider education. We need to get more screening happening on the ground. We need to be able to have more shots in arms, and that requires resources. So again, pointing back to the numbers that Adam gave. And then lastly, we have seen a new release for national strategies for viral hepatitis, HIV, vaccines, and STDs. And they were done in a syndemic way, trying to play off of one another. I think I said vaccines, but if I didn't, vaccines is in there too. And for viral hepatitis, it was touted as an elimination plan. And unfortunately, it's pretty hepatitis C heavy, but there are some very important pieces in there for hepatitis B community. And while that plan is written, its implementation is ongoing. And there are continued points among its implementation where we as a community should come in and really hit hard about the importance of including hepatitis B pieces. And then lastly, there has been movement in the last few months around the White House working towards a hepatitis C elimination initiative, a big test and treat program, and Hepatitis B United, Hep B United, and others are already pushing around advocacy and conversations to ensure that there are aspects of hepatitis B standard of care included into that, especially as it relates to the fact that hepatitis C treatment is supposed to have a hepatitis B screen before that. So that was my auctioneer talk. I know we're about to at time, but if folks are willing, I'd say, like, you know, if we can maybe have this go into like 2:40 to get a couple questions in, and then hand it right back to Daniel.
Thanks, Frank. And thanks everyone, Nora, Adam, and Frank, for this really fantastic overviews that I think it mixed, you know, a nice bit of realism that these are challenging times with some optimism. There's some really interesting opportunities and some really interesting thinking. I want to kind of straddle both of those by saying something that, Nora, your remarks kind of inspired me to think about, that over the last couple of years in the United States, around 2.5 years around the COVID pandemic, we've seen a lot of politicization of public health. A lot of division of public health, some communities really attacking the credibility of public health leaders, public health as a science, public health as an enterprise. But I can't help but think, you know, that TB is one of the strongest case studies that we have in this country for the power of public health to protect communities as well, and the role of public health in developing, fostering these new vaccination guidelines for hepatitis B, and reconsidering and potentially revamping the hepatitis C screening guidelines. So I guess I wonder how each of you, from your different vantage points, take the lessons and insights from hepatitis B and TB and talk about the value of public health to your family members, your friends, your community. Is there a good message that we can be spreading based on our experience and our work, and about the continued importance, value, and viability of public health?
I'll go first and just react personally because I think what COVID has shown me personally is how well sustained, under-resourced infrastructure really led to some of the not surprising events around the beginning of the pandemic. And it felt like every set of talking points or even just engagement that we had from my heart, I wanted it to be a love letter to people on the ground, but especially the hepatitis and TB folks. I was so inspired to learn how our TB program and really you on the ground, what you were doing and what sometimes we were funding, really built a foundation for the COVID response. And created those best practices, and I also think about our DIS workers and STD as well, just folks who understand how to get contact tracing done, and so it was really like you said, the epitome of everything that I knew theoretically could and should and was happening come together, and I'm even more inspired to talk about the value of investing in these structures that we know work.
Thank you, Nora.
Oh, sorry,
Go
Daniel.
for it.
Yeah, just and kind of I'm going to merge two things. One, I think COVID helped this along, but also I think the kind of ongoing drug use or opioid crisis did. I think both of those combined to shift a narrative around it can happen to you or your family. I think there was a lot of folks who are all like, oh, viral hepatitis as a potential risk factor from drug use. Never going to see it in my, around me or my family. A lot of folks early COVID are like, that's the cities, or like, that's not going to impact me, to then seeing, themselves or friends, neighbors, families acquire COVID or have substance use disorder issues or overdose deaths or other infectious disease consequences, and kind of just, being able to shift that narrative of, hey, public health isn't just everyone else. Like, it's you as well. It can happen to you. It can happen to your family. And really, there are things that you as a family unit can do to keep yourself safe.
I'll just add that I think there's really been a recognition that that public health is a collective responsibility, where we all need to be cognizant of the need to protect each other and protect ourselves from the various healthcare challenges that we have, and that any break in the system really does affect everybody, and the community and the society as a whole. I will also say, kind of building off of what Nora was mentioning, is that it really uplifted the need to really invest in the organizations on the ground who are doing the work day in and day out, and wanting to ensure that they have not only the resources and the support that they need to do their clinical work, but also that we are investing in the wraparound services and the other services that are absolutely critical to engaging with community, particularly with communities of color, whether it's language assistance, understanding how various diseases impact certain community groups, and really getting data at a granular level for different races and ethnicities, and ensuring that we are supporting the community, like I said, supporting the community-based organizations who are actively engaged with these communities on a day-to-day basis, and who are working with health departments, with healthcare providers, and ensuring that there is that whole of, really, it really requires a whole of community engagement. And I will also say that, when we're looking at the lessons learned in the TB and the hepatitis B space, and as well as other public health spaces, I really, the speed at which we were able to address COVID-19 is really a testament to some of the lessons learned that we have with other diseases, and the need to invest in a strong public health infrastructure. I think that, it's unfortunate that it continues to be polarized, and not just polarized for public health, but also communities, minority communities who have been disproportionately impacted. I know, the rise in anti-Asian hate has been a significant contributor to people leaving the healthcare profession, and we need to, tone down the rhetoric. I acknowledge that public health really does need investments, and support the providers and the support staff who are working, because when we talk about this racism and discrimination, it's not only affecting patients and other individuals, but it really does have a significant impact on the healthcare workforce as well.
Thank you all. I really appreciate how you provided inspiration from very different but totally complementary angles. Last question before we go to break. This is very rapid fire, and Nora, I will let you off the hook if you say in your professional capacity you cannot answer this question. But no matter what happens with the elections in a couple of weeks, we know due to retirements that there will be a cadre of new members of Congress. And that's always an opportunity to get them interested and engaged in our issues, our work, and our communities. Anybody have an elevator pitch in case you happen to be seated next to a plane to an incoming member of Congress in January about what you hope to see from them during their work, no matter which party they're a member of?
I would say congratulations on your election. It's always good to suck up to a policymaker, and really then just point out the fact that public health is bipartisan, and that even that in our last several administrations and different versions of Congress, we have seen things be passed that were beneficial to public health, whether it was responses to substance use disorder or other pieces. It wasn't the best, but the government can come together and figure stuff out eventually, and just really hope that they are willing to do what's best for the country and not necessarily have it be party politics.
Thank you.
Yeah, I would agree. I think that, healthcare is very personal. And I think regardless of political party, addressing healthcare challenges is a universal desire across the political spectrum. And in areas where we can find that common ground, and as I'm talking to new members, I would like to hope that they want to address the specific challenges within their district and the constituents that they're serving, and investing in a strong public health infrastructure, investing in a strong healthcare workforce, and investing in the linkages to care that we can provide for the constituents and the diverse communities that they are serving is something that we can work on together. And it's something that I think does span the political spectrum as well.
Thank you, Adam. Nora, how would you rate Frank and Adam's messages?
I give him a 10 out of 10. And I certainly appreciate the work that you do to make sure people understand the value and importance of our work. And I'm certainly here to serve both members and all of our partners and everyone doing the important work on the ground.
Thank you, Nora. And as I close this out, I'll just point out to everybody that Frank and Adam just modeled messages that anybody that can carry. They didn't use statistics. They did not have footnotes. That these are simple, common messages that we can all be spreading no matter where we're located. So I want to thank all of our speakers again for a wonderful session.